Welcome to the Wild Physio Podcast with your host, Andrew Wild. Today, I'm super excited. I haven't had an orthopedic surgeon on for a while, and today I have Dr. James O'Sullivan on. And Dr. James O'Sullivan has been treating patients in private practice in Lambton, Newcastle since 1998. He specializes in foot and ankle surgery with a keen interest in management of the diabetic foot, treatment of bone and joint deformity and trauma. Currently, Dr. O'Sullivan is embracing minimally invasive surgery of the foot and ankle, as well as arthroscopic ankle fusion and total ankle prosthetic replacement. Welcome to James. How are you?
Very well, thanks. Thanks, Andrew. Thanks for having me on.
Looking forward to it. Just a bit of backstory for the listeners. So back in my uni days, I actually stayed with James for 5 weeks, and we used to go surfing every morning while I did a placement at Jot Hunter Hospital all those years ago. It was probably 12 years ago we worked out, just before. Yep. Good times. We had a few battles on the tennis court. I got you, I think.
It's true. Only just.
Now I get you for sure, considering you've just had a hip replacement 3 years ago.
That's right. Yeah, that's right.
So let's just dive into the topic of Achilles ruptures. And before we go into how we would manage an Achilles rupture, let's just go through, how does an Achilles rupture typically happen? What is the mechanism?
Yeah. Well, it's essentially an explosive takeoff type of injury, if you want to put it that way. But over the years, the demographic of tendo Achilles ruptures has changed. It used to be, traditionally, when I did my training 25 years ago, it was the 40-year-old squash player who would classically rupture their tendo Achilles on the squash court. Whereas now, it tends to be more mixed. I mean, I'd still probably say that's the median group, but we tend to see a lot more now older guys in their 60s who may or may not be fit, but are usually pushing a caravan around Australia. And so as they push it and try and, give that extra exertion in the push, it'll rupture as well. So, but if you think about it, really, it's supposed to be a sort of a rapid acceleration injury, and usually with regards, it's a takeoff or a fixed foot and loaded. I mean, classically, you'll see them playing rugby league, rugby union, soccer, or basketball. Basketball's the big one in the States, where it happens traditionally.
And there's a lot of classic footage of people turning around as they rupture their Achilles, thinking that someone's kicked them in the back of the leg. That's happened a few times in AFL, I've seen.
No, that's exactly right. That's the classical story. And if you say to them, did it feel like someone kicked you in the back of the leg, and you turned around, there was no one there, they'll go, you're reading my mind.
Yeah.
It's such a classical story that, if someone comes in and tells you that story, it's almost pathognomonic. The pathognomonic sign, of course, is the Thompson Test or the Cullen's Test, which is the squeeze test of the calf where the foot doesn't move. But you could almost say that history is pathognomonic of a tendo Achilles rupture as well.
And when we're talking about the Thompson Test, if you were testing for the Achilles, how would you go about it when you are doing the Thompson Test? Because there's a lot of physio students out there that listen to this podcast.
So what I do, classically, the patient will come into my surgery, usually in a boot or a splint and on crutches, partial weight bearing. And so I'll remove the splint completely, and I'll get them to kneel on a kitchen chair quite comfortably, so that they're not kind of suspended and struggling, so that they move forward, but so that their feet are hanging over the end of the seat. But you want them relaxed. You want them to be able to hang on to the side of the chair so that they feel like they're not going to fall. And then classically, you can both look at both legs to compare, and you can squeeze both calves to compare. Okay. Now, just observing the affect of the foot is important, I think, because if they've got a complete rupture of their tendo Achilles, usually the affected side will be in more dorsiflexion passively than the unaffected side. So classically, the normal posture of the foot kneeling would be about 25 degrees of plantar flexion from neutral, whereas the patient with the rupture will have it like 5 degrees of plantar flexion or less, be in relative neutral position compared to the unaffected side, which is plantar flexion about 25 or 30 degrees. And then I usually identify the widest part of the calf, so it's classically in the upper third of the leg, and I'll compress the unaffected side first, because you want to have the patient's confidence and you don't want to hurt the patient. And sometimes there can be blood tracking up the calf that can cause discomfort, and that'll make the interpretation of the sign difficult. So I'll squeeze the unaffected side first and note to the patient that the foot so-called nods or moves. And then with the affected side, I'll be very gentle about squeezing the calf to avoid pain, but then try to apply the same amount of pressure. And even if I have to go backwards and forwards to elicit the sign, but essentially the foot does not move when you squeeze the affected side calf, and that's a positive test. So in some ways, it's not intuitive that loss of movement would be a positive test, but in this case it is. And that's because the integrity of the muscle tendon unit, of course, is disrupted completely.
Are there any other specific tests that you would use to confirm the diagnosis?
Well, then I would palpate the tendon gently. And again, classically, the rupture is at the level of approximately 5 centimeters above the insertion of the calcaneus. And usually, if the patient's slim, you can actually see the defect, but you can gently place your finger in the defect too, which implies that the defect is about 2 or 3 centimeters, often just widened. So I'll palpate it. But the Thompson's test is pathognomonic. That is, if they have that sign as positive, then that's the diagnosis. You don't need necessarily an ultrasound. You don't need an MRI scan, which often the patients come with when they see me.
Yeah, it's kind of nearly a given. I've only ever seen one acutely, and it's obvious. It's very obvious.
Yeah, it is obvious. I mean, it's a classic history, as you point out, and it's easy to examine for. But you generally, suspecting it by the history before you even elicit the sign.
And once you've got the diagnosis, what happens? What happens then? Because there's obviously several meta-analyses now, especially one that came out last year, when we compare conservative management, non-operative treatment versus the operation. How do you make the judgment whether you go down the operative or non-operative path? Yeah,
it's a really good question, and I think it's not discussed, let alone understood. And the treatment for a ruptured tendo Achilles can be either conservative or operative, okay? But certain cases do better with operations, and certain cases will do well with non-operations, okay? And just to clarify, say a high tear at the musculotendinous junction, okay? Now, they will classically do well with non-operative treatment and do poorly with operative treatment. So they're a good one to splint in plantar flexion, and we'll talk about the non-operative and the post-operative regime later. Operative treatment, if there's an avulsion of the tendo Achilles off the calcaneus, they do poorly with non-operative treatment, and they do very well with operative treatment. So they're best fixed early. So that's just to clarify those two groups. Then you have the majority of them, which is 95%, are at that 5 centimeter level above the insertion under the tendo Achilles. And my algorithm for non-operative treatment is that if you see them in the first 48 hours, you can generally treat most tendo Achilles ruptures non-operatively. And that the reason for that is because when the tendon ruptures, you do get a hematoma. But in the first 48 hours, the hematoma is liquid, okay? Whereas if you leave it longer than that, it solidifies and organizes. So the idea is that the tendo Achilles ruptures, it's in its paratenon, so it's in a very loose kind of delicate sheath. There's blood interposed between the ends often. But if you passively flex the ankle into plantar flexion, and let's say 60 degrees of plantar flexion, as long as the patient's comfortable, you will passively oppose the two endings of the ruptured tendo Achilles. So as long as you can splint them there and hold them there while it heals, you can treat them non-operatively. And you can do that successfully with most patients, I would say. I guess the exception to the rule in some ways is the elite athlete or the professional athlete, because they have professional pressures on them. That is, the sooner they can get back to their sport, the sooner they can earn their living, so to speak. Okay, that's being a bit glib. And in some ways, you can't speed up the biology necessarily, but you can speed up the rehab. So they probably are better treated operatively as well, but you don't have to treat them operatively.
It's interesting you make that point, because the Ochen et al. In 2019 said the return to sport for operative was on average 6 to 9 months and non-operative was 6 to 8 months.
Yeah, right. I don't know. I would probably say that that's difficult to discern, but you can certainly treat them non-operatively. I would agree with that. Now, on the other hand is, if someone's had a ruptured tendo Achilles and they've been walking on it for a week, that is not in a splint or in a boot that's in a neutral position, I believe those patients are best treated operatively. And the reason for that is that the tendon will heal if you don't operate on it, okay? It's not an issue with tendon healing. The big issue is getting the tendon to heal with the right tension on it so they can return to sport. And, you know, as I said to you, when the tendon ruptures, it bleeds, there's a hematoma. The hematoma organizes and heals the scar tissue, and then down the line, like 5 or 6 months, it becomes tendon ultimately. That's how long it takes. But the problem is if you have a hematoma that organizes and becomes a space-occupying lesion, tendo Achilles will lengthen by 2 centimeters or more. So the muscle tendon unit doesn't have the same tension in it ever. You cannot regain it with rehabilitation or physiotherapy, okay? So they end up with weakness forevermore in that leg if you leave it like that.
And a lack of power. I think that's the big
lack
one.
of power. That's right. That's what it gives you, you know. And they do get discomfort with it ultimately, and they get discomfort because they start to use their accessory muscles, the long flexors of their toes, to actively plantarflex their ankle. So they get sort of muscle fatigue, sort of pain in their calf, I find. But they can walk, but they can never go back to sport. You know, the Kubla Khan, when he used to invade, you know, and take prisoners, he would cut the tendo Achilles of his prisoners because they could march across the plains, but they could never run away. Bit of trivia for you.
There you go. I like that.
Yeah.
In regards to the surgery, what
Yeah.
happens during the surgery? What are you actually trying to achieve, and what does the surgical intervention entail?
Yeah, so really good question, because it's a really simple answer. What I'm trying to achieve is exactly what I'm trying to achieve with non-operative treatment. That is apposition of the 2 ends of the tendon under the right tension. So if I can't achieve it non-operatively, that is, I can't evacuate the hematoma or clear the hematoma to allow the 2 ends to become passively opposed, then I open it, I drain the hematoma, I remove the space-occupying lesion, and I then stitch in whatever way the 2 ends to oppose each other. And there's all sorts of different ways, you know, to do it, because it takes us down the sort of path then of, you know, well, when do you treat them percutaneously, or when do you treat them with an open tendo Achilles repair? Okay, and again, that's the next sort of algorithmic step. So in answer to the original question, you know, you can treat all tendo Achilles non-operatively because they will heal, but not all non-operative treatment will do well. That is, they'll end up with weakness or loss of power, particularly with that push-off phase of gait and that propulsion in running.
And when it comes to the surgery, what are some of the risks of the surgery, complications that you could potentially have post-operatively?
So the major risk is wound breakdown and infection. Okay, and that's the one that we all fear, and that really has brought on the generation of percutaneous tendo Achilles repairs to try and avoid that complication. So that's the major one. You can have deep venous thrombosis after the surgery. You can actually have, of course, deep venous thrombosis from the injury, and the incidence of that in the tendo Achilles ruptures is about 7%. That's all ruptured tendo Achilles, so not necessarily operating on it. But once you operate on someone, you cut the skin, there's risk of wound breakdown, with risk of infection. If you're really clumsy, the sural nerve is not far away, and that can be damaged, particularly if you extend the incision more proximally up the leg, because the nerve comes across the back of the calf and then heads laterally towards the lateral malleolus distally. They'd be the major ones. Of course, the tendo Achilles that you repair can re-rupture, after you rehabilitate them, or even during their rehabilitation, they can re-rupture. And I guess that's the other one, because the surgery in some ways is fairly simple, it's fairly veterinary, but getting them to rehabilitate, and you would know this, the rehabilitation in my clinic is 3 months, it's no cutting corners. And usually the last month is the danger period, because the patient is over it, they're feeling good, they're starting to move it, they're thinking, what is all this fuss about protecting me, for another month? And they simply do something stupid, take the boot off, step down a step and re-rupture it, and it's a disaster, because it's ground zero again.
Yeah, for sure. And post-operatively, or even in that non-operative conservative patient, what are you typically doing in those first 2 to 4 weeks with casting, booting, all that sort of stuff?
Yeah. So essentially what I do now is I basically have the same regime for my non-operative patients as my operative patients. It is a little bit different with the non-operative patients in terms of how quickly I allow them to actively mobilize, though, because if they actively mobilize into dorsiflexion, particularly beyond a neutral position, they'll stretch their healing tendon. So for the first 4 weeks for the non-operative group, for the foot, I put them in basically a front slab, a Dynacast front slab in maximal comfortable plantar flexion, which is about 60 degrees of plantar flexion, and allow them to touch weight bear with crutches. And that's important, because touch weight bearing facilitates some of the healing of the tendon. It also allows them to stimulate the muscle pump, so they avoid DVT or decrease the incidence of DVT, and it feels more biological doing that, okay? But in the non-operative group in the first 4 weeks, I don't really allow them to dorsiflex at all beyond that position. So they can take the splint off for half an hour to wash, and they can actively plantar flex their toes and even their ankle beyond that position. But in terms of dorsiflexion, I don't let them do it for 4 weeks. So I see them at 2 weeks and see how they're going. I usually see them at 4 weeks. And if they're doing okay, then I'll allow the non-operative group to actively dorsiflex to a neutral position. And I keep them there to the 8-week mark, okay? Because essentially, I'm really paranoid about the tendon healing in a lengthened position. Because as I said, you can't rehab that to tightness. You can rehab them if they're tight to get the movement back. But if they're loose, if it's lengthened, you cannot rehab them to tighten it, okay? So I'm really, really paranoid about it. And then at 8 weeks, I send them to a guy like you to start to get them to gait retrain and more aggressively regain the motion and strengthen the calf. So with the operative group, usually they're in the splint they're in the same splint, so 8 weeks in a plantar flexion splint. But for the first 10 days, 2 weeks, they're wrapped up and it's all left intact because of the wound healing issue, okay? But at 2 weeks, I see them, I remove sutures, and then I actively allow them to move to a neutral position. So that's the difference. And in some ways,
when you say neutral position, are we talking what, plantar grade here?
Plantar grade, that's right. Yeah, so to a plantar grade position. But again, that's it. That's all I really want them to do. Now, beyond the 4 weeks, you can be a little more aggressive with the operated on treatment, because you've got the insurance policy of having a strong suture in the tendon. Okay, but you've got to remember that the tendon is not tendon for 5 or 6 months. Okay, it heals with scar tissue, but it's 5 or 6 months before it's actually tendon tissue. So you want to be careful. And I try and explain this to the patients in terms of getting them back to running, jumping, particularly impact or takeoff sports, cutting sports, so that they understand the biology of it. And there's not a lot you can do to change that biological process. Okay.
Got to just give it time.
Yeah, so both for the non-operative group and the operative group, they're in a plantar flexion splint for 8 weeks, whether it's post-surgery or post-injury. And then at 8 weeks, I put them in a cam boot in a neutral position, allow them to fully weight bear, and send them to physio for regaining range of motion and strengthen the calf. But I keep them in that boot for 4 weeks. So it's 3 months splinted or booted. And as I said, that last month is the danger period, and that's what I tell them about, re-rupture or doing something stupid to it.
And then once you're hitting that 12-week mark, are you weaning them out of the boot?
No.
Or it's straight out of the boot?
Straight out of the boot, usually. I mean, by the time, I mean, it's a lot of my colleagues and the physios as well, I find, do to sort of remove wedges sequentially every 2 weeks, okay? And that might be fine under supervision, but I was still finding that, if I was aggressive about removing the wedges, I was getting the tendon healed in a lengthened position. So that's why I'm pretty paranoid about splinting them in plantar flexion for 8 weeks. Once you get them into a neutral position at 8 weeks walking, by the time you take that boot off at 4 weeks, they're ready to go. Yep. They you don't need to wean them out of the boot. They want to get rid of it. Often they'll admit to walking short distances at home without the boot, to the bathroom and stuff. And that, I guess, is fine. In some ways the boot's an insurance policy. In a perfect world with a perfect patient who understands what you're trying to achieve, you could probably remove the boot at 8 weeks. But my patients are not like that,
Could you use the boot earlier and put wedges in the boot to maintain that plantar flex position?
You could, but I find that a lot of boots, particularly the cheaper boots, what happens is because they're not secured firmly, the patient slides through them, and so you lose that fixed plantar flexion position. And often what you find is they slide through it and they're taking more weight on it than you'd like, and they're in a more relative dorsiflex position, so the tendon heals in a lengthened position. So the splint, I find, is fairly definitive. It's a front slab splint, not a back slab splint. So it stops them from passively or actively dorsiflexing.
Yeah, and when it comes to calf raises, when are you typically implementing calf raises into a rehab plan?
3 months. I think that's a really good question too. So I probably wouldn't allow them to do it to 3 months. At that stage, you could be certainly confident they could do a double leg heel raise, but you could segue them to a single leg heel raise just with time. So.
Yeah, and when it comes to running, changing direction, cutting based sports, is there a time frame on that? You typically want them to wait until they get to that point?
Well, I do leave it very much to the physio, because I see them at that 3 month mark, and then I don't see them for 3 more months at the 6 month mark. And I basically just say to the physio, when you're comfortable with them, you let them go back to running, jumping, and competing in sport. And usually the physios are pretty paranoid, I think,
yes.
if I give them that responsibility.
Yeah.
So I find that, I mean, in a perfect world, probably at 3 months, you could start to jog them, but they usually are not necessarily comfortable or confident doing that for fear of re-rupture, but they probably won't, if they've been rehabbed properly. And, certainly, it begs the question, when do you get the sportsman back on the pitch, sort of thing. And the earliest would be 3 months, but I would probably be playing the patient off the bench, so to speak, just leaving them play short periods and just see how they go, rather than fatiguing them and then having them risk, further injury.
When you say 3 months, you mean 3 months after the boot's obviously off?
No, 3 months after the injury. I think you could start to jog them.
Oh, right. In terms of return to actual sport, though, at 3 months?
Well, I think you probably could, but I think you would need to sort of reduce the time on the field or pitch. Do you know what I mean?
Yeah, and I think this is a good one for young physios out there, that there's a progression of calf raises to single leg calf raises to double leg,
right,
low amplitude plyometrics, and then higher amplitude plyometrics into, once they can single leg hop, I typically start them running.
Yeah.
And once they're running, then we're changing direction. We're adding in curved linear stuff as well. And then from there, it's a slow progression into training, closed training, open training, small games, then big games or matches.
So I guess from a surgeon's point of view, would that take to do all of that? Would that be a month of work minimum to get them back to playing, or what would you say?
No, so that's going to take a fair bit of time. If it depends, though, it depends on what they're getting back to. I think the sport, the level of the sport, their previous sporting history, So it would depend. But for something that's really high level, as you were saying before, something like a jumping sport, say for instance, they were a long jumper or they were played Australian rules football or something like that, which requires a lot of jumping. Well, their rehab's probably going to take a little bit more time than someone playing a little bit of casual tennis on the weekend. So
That's right.
I think it just depends. But I like that progression of, once they can hop single leg and they're having no issues, then they can probably start to run.
Yeah.
And then you slowly build them through your normal sport loading program where you're trying to slowly integrate, change of direction, all that sort of stuff.
Yeah. Yeah.
So I think it just depends on the patient. There's
That's
so many,
right. It
so
does.
many what ifs.
I guess from my point of view, my job is to get that tendon healed and strengthened by 3 months. You know what I mean? And then I leave it in with you guys and see the result at 6 months, sort of thing.
Yeah, exactly. And when it comes to the non-operative versus the operative, the re-rupture rates of either, what have you found over the years, but also just more recently as well, considering now it sounds like you're doing more non-operative treatment?
Yeah, it's in some ways it's difficult to interpret the literature when you read. The more you read, the more difficult it is to interpret. But what I quote the patient is that the re-rupture rate for non-operative treatment is about 12%. That's probably a bit exaggerated now. I think as non-operative treatment has become more routine and more standard and better supervised, and the re-rupture rate for operative treatment is about 2%, which sounds a lot, but everything's risk versus benefits. And, if you think about, well, any patient has, medical comorbidities, they've got other priorities often, usually in my practice anyway, it's work rather than get returned to sport, So there's those sorts of issues to consider. But if someone asks me straight, that's about the figure that I quote. I mean, but as I say, if I can get the non-operative patient to 3 months, I think the re-rupture rate at that time is almost equitable compared to operative treatment.
Yeah, and it definitely sounds like that sort of 6 to 8 week period after the injury or after the operation is definitely the period where you need to tread lightly. It's much like an ACL, actually. I tell my ACL patients to make sure that you don't do anything stupid in that period of time because things aren't very strong in that period.
Yeah. In some ways it is, but it's a bit more. The trouble with the tendo Achilles is that it's such a dynamic injury and it's such a dynamic recovery too, because you would think that the quadriceps is the largest tendon in the body, right? But it's actually not. It's the tendo Achilles. So, and the biology of that tendon is different too, because it's not a synovial tendon. It's in a paratendon, not a synovial sheath. So the healing and the nourishment of this is much more tenuous. The reason why it ruptures at the 5 centimeter level above the insertion of the tendo Achilles is because the blood supply is so poor there, and that has implications for healing and for the risk of wound complications, because again, healing's all about blood supply, and blood supply is poor to the tendo Achilles, the soft tissues around it, and the skin, of course.
Yeah, and for the physio students and new grads and everything out there, Gurong et al. In 2021 is a great meta-analysis on surgery versus no surgery. I had a really good read of that recently, and the difference between male and females with Achilles ruptures was very interesting. 84% of patients through that meta-analysis were male and 16% female. I found that very interesting. And what do you attribute that to, James?
I think in general, because there's more males playing takeoff and contact sports in general. I mean, that's probably becoming less so, but I don't know the statistic now, but if you looked at the number of males playing basketball, soccer, rugby league, rugby union, they would be the big takeoff sports, versus women in those similar sports, plus netball, I guess, is the other one. I still think it would be 2/3, 1/3. I don't know for sure, but that'd be worth looking at. Why is that? could there be biological reasons? Well, there could be, but in that area,
what I read through that meta-analysis, and my understanding of it was that men can create more ground reaction force when they do jump. So there's just more load on the Achilles tendon
for sure,
each jump. And also we're heavier. I think that's another factor.
Yeah.
On
That's
average.
Right. That's right. I mean, I guess there's going to be hormonal issues there as well, you know, and it does come into play, you know, because particularly as you think about, you know, women who are pregnant with relaxin and things like that, you know, where does that come into play with any tendon, you know, in a woman versus a man, you know, but I think in general you can think of it as in mechanical terms. You're right, you know, ground force reactions are greater in men. They're heavier. They tend to be more aggressive in terms of playing these sports anyway. I think that's probably the reason, you know, but I must say I haven't read a lot about that. So
yeah, it was really interesting when I didn't think it'd be that high, but
yeah,
after I read more about it, it did make sense for sure.
Yeah.
Now, when it comes to the avulsion fracture, when someone is rupturing their Achilles and it's avulsing off the calcaneus, so you said that they're pretty much someone that should be operated on.
They should be. They should be for two reasons. One is if it's avulsed, you can imagine that it's displaced a centimeter, 2 centimeters often, okay? And again, it will heal often with bone or scar tissue, but it's lengthened, so that's not satisfactory. So getting the tendon back into position with a bony fragment, it's a slam dunk in terms of fixing it. It's dead easy because you can just fix the fracture to bone basically. So it's quite nice. The other issue with that injury is that often the fragment of bone is quite large. It's like 2 centimeters, 3 centimeters, and it rotates as it happens. So it tenses the skin. So it also becomes a risk of creating a breakdown of the skin and necrosis, and that's a disaster for that area. You know, so you can end up with an ulcer with the bone coming through it from that injury. You know, if it's not attended to or fixed.
So when you say it flips, so it's flipping completely the other way around. So
it'll often flip 45 degrees, sometimes 90 degrees. So you can have a sharp piece of bone under the skin that's prominent.
Gotcha.
So it's not satisfactory. But just from a biomechanical point of view, you're better to fix it back to bone to get the tension right in the muscle tendon unit.
Yeah, and after an Achilles rupture, and whether they go down the non-operative or operative path, they'll often have a thicker looking tendon.
Yes.
Now, a lot of people have said or asked me in the past, will this ever change? Because aesthetically, I hate it. I've had a couple of women, especially, they're like in high heels. I don't like the look of it.
Yeah.
Is that just a given? It's just going to be there forever. It's going to be thick. It is what it is.
Well, it does get less with time, but I tell them it always will be thicker than the normal side. So, and the risks of doing anything to reduce it are so great that it would be not my best practice to think about doing anything to it for cosmetic reasons. Because you know, like I you know, just this risk of wound breakdown is, when it happens, it's so bad because again this area is so tenuous. If you get an infection and the wound breaks down in that area, what happens is you end up with sort of a large ulcer and tendon on show. It's just a disaster, and it's really difficult to salvage it in a satisfactory manner. And I think about it, like when I was doing my training, I remember like an 18-year-old female German backpacker who ruptured her tendo Achilles, and we operated on her. And for all intensive purposes, she should have done well, but her wound break down, and it was a disaster for her, you know. And even in a fit, healthy 18-year-old, you know, it just really made an impression on me, you know, about the risk of surgery in that area. So it's going to remain thickened, unfortunately, and it's just the way it is.
Got to just deal with it.
Well, just send them to a psychologist for it. You know?
Exactly. Now, something I read with the Ochen et al. 2019 paper was, if you have Achilles pain, you are unlikely to rupture your Achilles when it is painful. Let's dive into that and Achilles mid-portion tendinopathy.
It's a really good topic to talk about, because the other topic we were going to talk about is Achilles tendinopathies. And so there's basically two types of Achilles tendinopathy: non-insertional, where tendo-Achilles ruptures occur, and insertional on the heel, which is probably more common. But the big issue is often with someone with a non-insertional Achilles tendinopathy that is above the heel. Is my tendon going to rupture, doc? And they do ask that. The answer is no, it's unlikely to, although it's possible. And the statistic that I quote, which is somewhat tangible, is that of the tendo-Achilles ruptures looked at in the study, I can't remember whose study it was, about 15% of them had prodromal syndrome problems with the tendon before it. So if you ask, it's worth asking the patients, because I've started to ask patients, did you have problems with this tendo-Achilles prior to it rupturing? And the answer, a lot of them do say yes, but the statistic is about 15% have had the problem. So although it's possible, if you have a non-insertional Achilles tendinopathy, it's unlikely is the answer.
Because a lot of people out there would probably reason that if they did have an Achilles tendinopathy, they're probably at a greater chance of rupturing their Achilles tendon. Now, why do you think that is, that if someone does have an Achilles tendinopathy, that they actually are unlikely to?
No, I wouldn't say that. I would say they are likely to. Sorry, they're more likely to than if they had a normal tendo-Achilles.
Yeah, but it's still pretty unlikely, considering it's what, 15%.
That's right.
Yeah,
it's still unlikely, and that does intrigue me, because you would think that if they've got this degenerative change in the tendon, and it does go from just some diffuse swelling of the tendon to full on like a mucoid degeneration of the center, and if they have it long enough over years, they'll get a cystic change in the tendon. But I think what happens is, although the tendon is more likely to rupture, the patient activity modifies before it becomes an issue. So they don't do the high impact sports on it. They seek treatment for their Achilles tendinopathy.
Yeah, I completely agree. I was about to say that people change what they do, and they also can't express enough power often to probably get it to the point where it maybe ruptures.
Yeah.
I think that's another factor. And Ebony Rio, who's a world leader in tendon research, tendinopathy, Achilles tendon pain, she often refers to the brake and the accelerator when it comes to the motor cortex. And when someone does have a Achilles tendinopathy, often it's kind of like the brake and accelerator on at the same time.
Yeah.
And you can't express what you previously could in regards to your athletic potential. So maybe that's a factor as well.
I think that's right. Like if you think about any sort of musculoskeletal ache and pain, what do you do with it? You protect it. And you might just say, well, it's just pain. Why can't I work through it? But your body doesn't kind of let you, even if you think I can tolerate this, I don't need to take anything for it. But you do develop stiffness of the joint. You do inhibit its activity to protect it, and I can believe that it is a cortical kind of reflex that does that,
It's fascinating. It's been a fascinating chat, James. Thank you so much for your time. Have you got any last words or anything to add?
No, I would just say that I think it's a great topic, Achilles tendon ruptures. I think it's a common injury. It's a well-known injury. I think what's not well understood is the biology of the tendon repair, as you point out. And I think that there could be sort of more work done on it in terms of, how do we get it to heal? How do we get the muscle tendon unit to heal in a tight, position, if you like, to maintain strength when it is healed? And how do we rehabilitate it back to sports and normal function? It's a great topic.
Yeah, no, I agree. I really love chatting about this sort of stuff, and the Achilles tendon's always fascinated me. And for the listeners out there, there's a great topic of discussion I had with Jill Cook and Ebony Rio, and also I've done a separate one with Dr. Peter Maliaris about Achilles tendinopathy and just tendinopathy in general. So if you wanted to learn more, jump onto that. It's on my podcast website and YouTube. Now, James, one last question. Have you got any advice for physio students, new grad physios, or even some orthopedic surgeons out there or budding orthopedic surgeons?
No, I would say, look, if you're interested in this sort of stuff, make yourself known to, physiotherapists like yourself, Andrew, and to orthopedic surgeons who do this sort of work, because they'll welcome you into the operating theatre, and you can see this stuff pretty graphically. Seeing the anatomy and the pathology is fascinating for most students, and it really has a big learning impression on them, makes a big difference to them in terms of motivating them. So, everyone's keen to teach, and I think the more enthusiastic is the student, the better. So, come on into surgery with me if you like.
Very well put. And where can listeners find you? Do you have an Instagram, Twitter, email, website?
I do. It's gone a bit stagnant. I've got a Facebook page, but and I do have. I used to put a monthly sort of picture and post, just brief on it. But there's a number of topics on my website to look at, including tendo Achilles rupture, with some pictures. But give me a call anytime. I'm on the phone. I take calls from physios and GPs and all sorts of allied health people anytime.
Thanks again for your time, James. This podcast is live on Apple Podcasts, Spotify, all the podcast channels. Thanks again, James. We'll have to catch up in person for a surf soon.
Congratulations. Thanks, Andrew.
As usual, stay strong.